Welcome to the Tea on THC. Today's episode is with Dr. Jon Samet, former Dean of the Colorado School of Public Health. The Tea on THC is powered by Colorado School of Public Health. Welcome, Jon.
Thank you. Glad to be here.
So, Jon, my first question to you is, I want a little history on your illustrious career and how we ended up working together today.
Okay, this is a long trajectory, but I'm going to shorten it down. Just briefly as to my background, I studied medicine and trained in internal medicine and pulmonary and critical care medicine, but also public health and epidemiology. And I was drawn into this combination because at the start of my career, I was very interested in air pollution and tobacco and how the lung was harmed by what we breathe. And I've spent since my training, over 4 decades, doing research on things like secondhand smoke, active smoking, radon, indoor air pollution, outdoor air pollution, and more, both nationally and internationally. Over time, I shifted out of the clinical world into the public health world, becoming an administrator, a department chair, and a dean, and really having the opportunity to shape programs of education, shape programs for public health. And sort of my position here, my last major job as Dean of the Colorado School of Public Health, led to my being involved with House Bill 1317 and cannabis.
And Jon, say a bit more. I mean, for instance, you're going to Japan tomorrow, and you've been there 40 times. I think the complexity of your career is hard to describe in a soundbite. So please talk about some of your work in Japan and other points of interest.
Because of the research I've done, I've been always engaged, I think almost from the start, in sort of matters of what we call public health practice, policy translation of science into evidence. So with that, the cannabis project fits well because we're involved in sort of translating what we know scientifically into educational campaigns or potential policy routes. Japan, for example, is to fulfill my responsibilities as a board member at the Radiation Effects Research Foundation, which carries out the studies of atomic bomb survivors. I'll note historically that this is one of the longest running epidemiological studies. Of course, the bombs were dropped in 1945, and here we are in 2024, approaching the 80th anniversary of the blasts. And there, we are working to assure that the right science is done and that the foundation, which draws on really the willingness what the survivors have given to humanity, is used optimally to provide evidence. And again, these studies have been, for a long time, the source of information on what are the risks of radiation.
And Jon, public health came in some respects to greater public awareness during COVID. For better or for worse, people have hardened opinions now of public health. What would you like our viewers to know about public health from a perspective of someone who's spent their career in public health?
Sure. I think obviously those two words, public health, got a lot of attention during the pandemic, and I recently wrote a piece on what comes next for public health and how is it going to be transformed. And we identified 7 areas that need to be addressed. One of them is politics and polarization and politicization, which is a threat. That said, public health is essential, and it's about promoting the health of all of us. And as I describe it, if public health is working well, nobody knows it's working. Nobody ever comes up to me, well, that's not exactly true, but people don't come up and say, gee, thanks for giving me an extra half year of life expectancy by doing X. So, we are working in the background. Our work affects all, which is where the public piece comes from. And, we shouldn't see public health as necessarily fully separate from clinical care. I mean, they really run together. And so much of healthcare, what doctors and other health professionals do, is about prevention. So ideally, this all fits together. But public health is operating at the population level and not taking people one at a time as they walk through a door into a clinic.
And inherent in that, Jon, is a bit of tension, that tension between the individual and the population health. So, and my background is someone with a law degree, master of theology, and an ethicist. I think that's something that's hard to explain to the public sometimes, and particularly the trade-off. So, as we pivot to discussing THC, can you set up some of the challenges of this population health approach versus the individual approach?
We need to do things at the population level to benefit everyone. And sometimes people may not like those policies or interventions because of course, everyone sees themselves from their individual lens. The easy example right now, why do I need to wear respiratory protection, a mask, distance by 6 feet, or get vaccinated? So, I think that played out in such real time with the COVID-19 pandemic, but that tension has always been there. It's been there around vaccination, it's been there around other measures. And another great example is raw milk, for example, which is pasteurized to deal with certain pathogens, and some people want raw milk. And then they have to take different steps if they want to get it. And this is coming up now as a tension with the avian flu, which is in milk, and the question of whether there could be transmission. So there's always sometimes those trade-offs between how people view their own individual liberties versus population health. A good historical example comes to mind. So I'm flying to Japan tomorrow. 30 years ago, if I flew to Japan, I would get off the airplane with a headache and a sore throat because there was so much tobacco smoking on the airplane. And there, people saw that they had a, quote, individual right to smoke and contaminate everybody else's air. So that's a great example, and this tension certainly played out, and the tobacco industry took advantage of that tension, as we pushed for indoor smoking bans.
Thank you for that great background. I think it sets a context for our viewers and kind of resets, hopefully, some of their thinking on public health. Let's talk about HB 1317 and your role in what the legislature has charged Colorado School of Public Health with doing.
HB 1317 was passed in 2021. Some members of the legislature were concerned about what was in the marketplace, particularly products that delivered a lot of THC, and the potential impact, particularly on youth and young adults who were using this at a time when brain development was still going on. Of course, there were other concerns, the fetus, use during pregnancy, postpartum, while breastfeeding, and more impact on those who might be at risk for mental health problems or have mental health problems. So the legislature asked the question, can we set a concentration limit in products? And after thinking about this, looking at the evidence, they realized that the evidence wasn't there. Included within HB 1317 was a call for the Colorado School of Public Health to do a review of all the evidence available to see what could be said about potential risks, and then also to develop an educational campaign based on the findings from that review. The dean of the Colorado School of Public Health, which at that point was me, was charged with leading this effort. And 3 years in now, practically, as ex-dean, I'm still leading the various components of this project.
So, Jon, that's quite a charge. Heightened responsibility. You're up for the charge as a seasoned public health professional. But tell me about the research. What did the research find?
Right. So we scoured the literature. When I say scoured, we systematically looked for all articles that might be helpful. So we started with over 60,000 and winnowed down in the end in our first pass to about 460 articles that we thought were relevant, from which we extracted the data. That first pass was revealing, because what we found was that there was not really much literature that addressed what is in today's marketplace. Not surprising. And the other finding was that much of the literature was just not of very good quality. Part of that relates to the complexities of doing research on cannabis, the lack of funding for it, the lack of standardized methods. So when we put everything together, we really said there's not much here that could lead us towards a particular concentration, for example, that should be a threshold for protection against risk. We are in the process of finishing updating our search, and this go round, just for 1 year, we're now extracting data from I think about 160 papers that we think are relevant. So it looks like the literature may be starting to catch up a bit with what's in the marketplace. But, if we do a study today, the scientific process means that those results are going to hit the street in a couple of years at the earliest. So we're always going to have this challenge of this science lagging, but we're still going to have to make decisions. And we're still going to have to educate and provide for the public and those segments of the public at particular risk what we know so that they can understand what risks may come with using cannabis or, what benefits might be supportable.
With imperfect data, seeking to make decisions that are supporting our nation's health, and in this respect, Colorado's health. So talk to me about THC. Our viewers are here for the T on THC. They want to know more. So talk to me about THC and kind of what the research says so far. What can we conclude?
Right. And of course, THC is only one of the cannabinoids that comes with cannabis, and there are others. But THC is the molecule, of course, that goes to the receptors in the brain and does this activation that leads to the responses that people like. The complexities here are that people can get THC into their bodies in many different ways. Still, the majority of products sold in Colorado is flower, so smoked generally, and but that proportion has dropped down over the years as other kinds of products have become available. And of course, now products are available that are in the form of edibles, in the form of vaped liquids that, very similar to what an e-cigarette is, a device that creates a small aerosol that goes right down into the lungs and it gets quickly to the brain. There's the extracts that are used with so-called dabbing, heating it up and inhaling this high concentration fumes that are emitted. Hashish, again, a resin with high concentration. So the marketplace is now quite complex, and I think there's both a range of products that can deliver a high concentration, and then historically, the concentration of THC in cannabis has gone from 3 or 4% from the 60s to somewhere around 20% on average now. So again, what is delivered by smoking is quite distinct from what was, let's say, back in the 60s or 70s when sort of marijuana sort of reemerged onto the social scene.
Yeah. So, John, you're speaking about this range of products, and at the same time, you're talking about THC levels. So, what guidance is there? Are you concerned about certain products more than others, or certain concentrations more than others? And if so, why?
At bottom, we should be concerned about how much THC gets up here. And, I think in terms of risk, I'm particularly concerned by those products that deliver a high concentration rapidly to the brain. So, that would include, of course, vape pens, dabbing, some of the other products. That's not to say that, using edibles, the same ultimate amount, it can get to the brain. It's just the time course is going to be different from the immediate hit. So the lung has a surface the size of a tennis court, okay? And so if somebody inhales something that reaches the air sacs, the alveoli, that has this huge surface to deposit on. And then it's a little over a 10-second pathway to the brain. So there's an immediate hit. So if you go to tobacco for a moment, nicotine is addicting. A smoker takes a puff, and within 10, 12, 18 seconds, that blast of nicotine has reached the brain. And all those receptors that are calling out for nicotine in a nicotine-addicted person are getting that hit. My concern with the products that are inhaled or other products that deliver high concentrations, there is that risk that comes from delivery of so much in such a jolt. Again, I think I'm concerned about any product or the way the product is used, which of course figures in to get a large dose of THC up to the brain.
And you also mentioned the particular concern of certain groups, such as pregnant people and youth. Why are they at a greater concern for you? What does the research indicate?
Sure. There are a number of different groups we're concerned about, and I'm sure as we do more research, we may identify more. But certainly we are concerned about anything that reaches the fetus. And this, of course, the 9 months of pregnancy are a remarkable time of growth and development, and worried about what might be the consequences of THC reaching the developing brain. Again, turning the tobacco analogy for a moment, we know that nicotine exposure during gestation is not good. And smoking, for a variety of reasons, for example, reduces birth weight by 250 grams on average, so roughly half a pound. Another period, again, going back to pregnancy, of risk is during breastfeeding when the THC or nicotine or whatever else in breast milk will, of course, reach the child. Looking now to older age groups, the brain of the adolescent is still developing. In fact, brain development seems to go on until about age 25 with some pretty important stuff taking place related to cognition and what's going on up here. Any pharmacologically active agent, we've been concerned about nicotine and now THC, might have effects that are perhaps lasting during this time of brain development. There's a substantial literature, and again, we're looking at that literature more closely on THC, cannabis use, and mental health. Some people use cannabis because they feel it benefits their mental health, but there's also a body of literature that we're looking at now about adverse consequences, for example, a first episode of psychosis or exacerbation of underlying mental health problems. So again, I think this is an example of another group where we need to be concerned about the consequences of cannabis use for mental health and be able to take appropriate steps to provide warnings, to educate healthcare providers. Along that line, part of our effort under House Bill 1317 is to reach to healthcare providers that provide care for those groups. We did a continuing medical education activity for those providing care for children, for pregnant people, and that's an important group to make aware of the potential consequences of what is in the marketplace. We'll be working with our Department of Psychiatry for a similar sort of activity in our coming year.
So do you have specific guidance, Jon, for pregnant people or children in this regard?
Well, I think for pregnant people, the answer is abstinence. I mean, I think, we can't specify that there's some safe level. And I think if we look at how social norms have changed around tobacco smoking during pregnancy, alcohol use during pregnancy, clearly we've gone as the norm. And I think a pretty widely accepted norm that the best thing for the fetus is no exposure. And I think the same sort of stance should be adopted for THC for really the same sort of biomedical reasons, that here is this remarkable growth and development going on, and everybody wants the healthiest child possible. So why expose that developing child that's got a long way to go to continue developing during childhood and adolescence? Why expose that child to something that may be harmful? And again, I think there's from what we know about other substances and initial work with THC, there's a good basis for concern.
What's your message to parents? What should parents be telling their kids about their developing brain and the risk of using THC?
Of course, a real challenge for those of us who have raised children, and I think it's been a while since I did that, and I can understand that the complexities are even greater now because of the variety of products that their children may have access to. The simple message of don't use it doesn't seem to resonate, and I think there's so many pressures, peer pressures, access that I think parents need to prepare their children for what is to come, what choices they're going to have to make. I think parents need to understand that there are products out there that deliver high concentrations of THC, and they shouldn't draw on their whatever experience they may have had with smoked marijuana, for example, in the past. I think they do need to, quote, get the T on THC, because I think that's really important. And I think youth have to know, and risk-taking, of course, is inevitable with adolescence and extending into young adulthood. I think for those who have mental health challenges, it's probably particularly important for them to know and understand that there's reason to be concerned about the risks. I do think, and that's information that, of course, Initium and others will be getting out, they really need to understand that we think risk for adverse complications of use of THC goes up, the greater the risk. So products that deliver higher concentrations should be considered with caution. There's something called the precautionary principle, which says if you don't know the risks, be careful. And I think that's a really important message right now.
Well, John, on that particular point, we do know that states such as Vermont have chose to legislate the amount of THC that's available in recreational marijuana. Given your comments, why don't you suggest that Colorado go down a similar path?
Yeah, there's a couple of approaches that could be taken around concentration. One would be to limit it. Another would be to tax based on amount of THC, for example. So there are potential policy measures. I think the challenge right now is saying, yep, this is the threshold, as Vermont did. And if I don't know if Vermont's level has been challenged, but it could be, because from what I know about the scientific literature, you couldn't turn to some particular concentration, say for solution delivered by a vape pen, and say it can't be above 50%. But if you want to be precautionary, again, you set concentrations lower. So I hope we get the science that is needed. There have just been so many barriers to doing good research. I mean, for example, for research funded by the National Institutes of Health, the only allowable cannabis has been that prepared by several institutions for research purposes. For a long time, the level of THC in the cannabis available for research was 3%. Now, that had nothing to do with today's marketplace. So, again, I think we need, if you ask a researcher, what do we need, they'll always say more research. Here, it's justified, but research that answers our questions.
Yeah. Well, anecdotally, we've heard, and I've heard directly out of the mouths of some youth, that they had perceived that they had acquired anxiety disorder as a result of their use. Tell our viewers the accuracy of those statements. Is that urban legend, or is that a possibility?
Well, urban legend can have truth embedded in it for sure. And I will say, some will say, of course, that cannabis helps them with their anxiety. And, this may be circular because maybe it does, but then they need to keep sustaining it. And now we have a sort of situation of tolerance and addiction leading to cannabis use disorder. Lots of research that is not of good enough quality to directly address your question. But, frankly, I tend to think that a lot of anecdotes coming from experienced users are probably telling us something.
And we know that from a campaign perspective, getting the voices of users and the voices of the community definitely shapes positively the impact of a campaign, and that is our charge. Jon, you've had an illustrious career, worked at USC, Johns Hopkins, Colorado School of Public Health, traveled internationally. Where does this work rest in the kind of continuum of work that you've done to support public health in this nation?
Well, I'm glad I'm doing it. I think if you'd asked me 10 years ago, would I be spending the waning years of my career on cannabis, I would have probably said no. But, I think across my career, I've been willing to take on big public health problems, whether tobacco or air pollution, and work nationally and internationally. And I think this fits in well with the kind of challenge that I've been engaged with. I think it's one that needs our attention. It needs some sort of big picture thinking, which we are trying to do. And so I'm pleased to be sitting here with the opportunity afforded by House Bill 1317 to help guide the Colorado School of Public Health and all our collaborators like Initiative in taking this on.
Great, and you're the man for the job, I would say, Jon. Final question, Jon. So on a personal level, I want your thoughts on the fact that we all know that Colorado took the nation, in some respects, the world, down the path of legalization of cannabis at a recreational level. Talk to me about what that means in terms of the heightened responsibility for Colorado to get this right for its community members, but also to get it right on behalf of the nation.
It's a very interesting question. And of course, Colorado was out there first, and 10 years ago, if you said you were heading to Colorado, people would smile. So I do think, since this, quote, experiment has been going on longest in Colorado, I think we have the opportunity to learn and understand what are the consequences. I think we also here have the opportunity, I think House Bill 1317 is timely to sort of look at what has been going on and to think about how to make certain that public health is protected as it can be against whatever threats are posed by the current cannabis marketplace. So I think House Bill 1317 in some ways has put us in the lead. The review that we developed, these 460 initial articles, and now adding to it, we've put into a database that's publicly accessible. It's unique. It's being used, we know, by thousands of people, or these thousands of accesses. So I think Colorado has done a service there, and one that I think should be maintained. I think our experiences with the various campaigns that have been launched and their evaluation are going to be important in providing some examples, hopefully of successes, but also of things that likely don't work to other states and nations. I mean, now, of course, there are other nations where cannabis is legalized. So I think we're doing things. I think it was very thoughtful impression of the legislature to put together House Bill 1317 and fund it. And Colorado School of Public Health is working very hard to address the task that was put in front of it.
Well, Dr. Jon Samet, originally of Newport News, Virginia, thank you for your service to the state and to the country. And thank you for joining in on this episode of the T on THC, powered by the Colorado School of Public Health.